Are most people in yet?
We've got you and I, and we've got two more. Hi, Libby. Hi, Sonia.
Hi.
And we've got some
Can you hear
more.
me?
Yeah, we can hear you fine.
Lovely.
Right, can everybody hear me? Hi, Judith. How are you? Right, so, and everybody can see the slides, so okay? Yeah. There's only a few of us today, so I'm quite happy if you want to turn your mics on, and you know, when you want to speak, you know, please don't sit there and not say anything, or otherwise it's going to get really boring. So yeah, please turn your cameras on, turn your mics on, and I'm quite happy for everybody to join in as much as they can. Right, I think everybody's in. So welcome to level 1, repeat prescription training. Okay, no problem. If your cameras are not working, we've all have IT issues. Level 1 training, this is, you know, quite basic, but some of you, there might be some information that can, you know, will be useful for you going forwards, and you know, everybody has different ideas, so like I said, please feel free to share and speak. Sorry, the rain in here is awful. Right, learning outcomes. This is to understand medication reviews, the benefits to sending prescriptions EPS full, understand the roles and responsibilities of everybody involved in repeat prescriptions. Wow, that's loud. And identify advantages of effective repeat processes. And understand the good practices you have at your surgeries. So, as prescription clerks and technicians, we do like 60 to 75% of the repeat prescriptions. So you're the first port of call that the patient will speak to, give their request to, and talk about all the problems, or if any they're having. We control most of that production and what happens. You do need clearly defined roles and SOPs in place if you possibly can, because if you have a good system, everybody has a role, and it will start with the request coming in, prescription clerk, then technician, pharmacist, GP. So if everybody knows what they should be doing, it should work quite smoothly. But as we all point out, errors can occur at any time in this process. So just a little quiz, 10 minutes, have a quick look at it, see how many you can answer. Just put your answers in the chat box. And the rain might stop, I might be able to hear myself think now. I don't think I picked the best room. All of you here today, do you work in your practices, or are you PCN? Or do you work for individual practices? Just type it in the box. It just gives us an idea really of who's doing what. I work for HealthWest PCN, so I'm the senior pharmacy technician there, and I'm also the prescription hub manager. So if you work in a hub, just put hub, if you know, and just gives us an idea really how many hubs are out there, what's going on with repeat prescriptions. Well, 5 surgeries, 7 Vale. That's a lot. I thought 4 was enough.
Yeah.
How many patients?
Over 30,000.
Oh, right, okay. Yeah, gets interesting when you've got 5 surgeries.
Oh, yeah.
All doing different things. Oh, lots of PCN then. Right, anybody got any answers to the first one? You do it one by one if you like. Right, most of you seem to have the first one right. Yes, it was an Iron Bevan who first established the NHS. First heart transplant, it's quite a surprising one, I suppose, 1968. Yeah, I thought it was 70s, but no, 1968. It was quite early. Right, so considering I think we're all female here today, what percentage of the NHS workforce is female? It's actually 77%.
Wow.
How long is a prescription valid for?
6 months.
Yeah, it should be 6 months. They do tend to get returned before the 6 months, but yeah, it should be returned. It should be 6 months. And obviously most of you know what PCN stands for, because most of us seems to be primary care network. And like you say, anything that leaves the pharmacy straight away is waste, even if they've opened the bag or not. As soon as they walk out that door, that prescription, that medication, if it's the wrong medication, wrong strength, not enough, or any other reason, unfortunately goes straight in the bin. So I think you all did quite well on that one. Right, so in the chat box, or put your mics on if you want to, this is about the legalities of a prescription. So there's certain requirements of a prescription that has to be on there. Can you name any?
A stamp of where the prescriptions come from.
Yeah, the address of the prescriber.
Yes.
Yeah. Actually, the date of birth is not a legal requirement, strangely enough. Their age has to be on there if they're under 12. And if it's a hospital prescription, it would be their weight. But actually, no, it's not date of birth, just the age under 12. I know, considering we use the date of birth to check everything, it's not actually a legal requirement. Pharmacy, nothing to do with the pharmacy really. Anybody else got any ideas? Right, so it's got to have the date on it, because otherwise you don't know how, if that's still legal, if it's a 6-month script, if it's been done a month ago. So it's got to have the date on there. Has to have the full name of the patient, also the address of the patient, and it has to be written or printed in indelible ink. So it can't be something that can be easily rubbed out. And if you've got a controlled drug, that comes with other legal requirements, like the form of the preparation. So you can't just put, I don't know, temazepam. You'd have to put liquid tablets, capsules. Also the strength of the CD has to be on there. Quantity, words and figures, and also the dose and the directions. We're getting quite a few returned at the moment. A lot of pharmacies are not accepting, say, MST, 10 milligrams, TDS. It has to be one to be taken 3 times a day. We've had a lot of ADHD medication returned to us because it's just got on there, I don't know, say Concerta, say 10 milligrams. I know it's not that strength, but OD, it has to be one to be taken. I'm not quite sure why the pharmacies are not accepting it without the one to be taken. Some are, some are not. So we're sort of going through all ours at the moment and making sure we have one to be taken daily or one to be taken twice a day, so that the prescriptions don't keep getting returned to us, because it just takes longer then, doesn't it, to reprocess everything. And how long is a prescription valid for, a controlled drug prescription? Anybody? Yeah, it's 28 days. And that's it. Once 28 days, it becomes sort of invalid. And how many months supply should you put on a prescription for a controlled drug? Yeah, it should be 1 month only. The GP can prescribe more than a month. It's not a legal requirement. 1 month is best practice. If the GP wants to issue more than a month, but it just needs to be documented in the patient's notes why that patient needs 2 months supply. When I worked in Wales, it was obviously we gave a lot more than 1 month, because people lived in rural areas and it wasn't always easy to come and pick up their prescriptions, so they were allowed more than a month. But that documentation should be in the records. So this is a bit about why is it a controlled drug? What makes that certain medication controlled? It's classified by law by the benefits that it gives, but also the harm it causes if it's misused. So the more chance of it being misused, the more chance of addiction, the more chance of, overdose, the higher the regulations. So they're grading it into a class and schedule. If any of you want to read the Misuse of Drugs Act 1970, when all the information is in there, but it's quite long. And like I said, everything should be 1 month supply. You can see in the BNF what schedule they are, how they should be stored, because a lot of the schedules and the classes also sort of collate to how they're stored, whether they're in a lock cupboard, are they put into the register, and are they registered out, how many signatures you need to give them, to take them out of the register. There's lots of different requirements, especially around storage. Right, we all see them, acute prescriptions. These should only ever be for a one-off issue or a trial of a medication. One of my technicians now is doing a little bit of a project, because we notice we have, across our 4 practices, lots of medication that have been on there, some of it 2-3 years. We're moving it to repeat, because if it's not an antibiotic and the patient is constantly ordering it, and we're finding it a lot with, omeprazole. If you think of anything that you've seen, please, like I said, raise your hands or put it in the chat box, because I think we all probably see the same things. And like I said, I'm getting a lot of omeprazole, lansoprazole, bisoprolol, and things that patients have been taking for years. I just move them to repeat and just put a little note on it to the doctor, say, look, that's been sat on acute for 3 years, so I've moved it now, put it on to repeat for the patient. I always tell patients when they ring up and say, I can't see my medication on the app, it's a new medication I've just had from the hospital. So I always say to them, there's usually a trial period of 3 months. Once that 3 months is up, it should be removed, it should be moved to repeat. So you can either ask the GP when you go for a review, or you can give us a ring in the hub and we'll make sure that we ask the GP to move it to repeat for you. Because if you're using the app, which I'm finding more and more people are now, and even in Wales, we've got the NHS app for the first time to order our meds. Yay, we're a bit behind, but we got there. And of course, if it's on acute, you can't see it. You can't order it. And then it gets really frustrating, because you write a note and nothing gets done, and it's still the thing that you've got there in the background still is not being issued. So, it does help patients a lot if that regular medication can be seen on their app and they can order. And like you say, the acute thing should be your amoxicillin, your codidrol, your temazepams, your one-off issues that people are not going to be having long term. Do a lot of you see a lot of acute medication on your patient's records that really shouldn't be there? Where do you live in Wales, Sonia?
Chepstow.
Oh, not too far then.
No, it's not a far. I get to work sometimes quicker than a lot of the people live in Bristol.
Yeah, well, I live in between Cardiff and Newport, and
Okay.
I still get home.
I knew you were.
Some of the girls.
Yeah, I knew you were.
And like you say, sometimes people who live in Filton and all are still trying to get home, and I'm like, oh, I've just got in, and they're still on the road. So
unless the bridge is shut.
Oh no. It still beats driving across the city, though.
Oh gosh, yes.
And you find, I don't know, but I do find NHS England, I do a lot more over here than I would do in Wales, so that's nice.
Yes.
A little bit different. Yeah, a lot of creams. I see a lot of creams on, you know, and if it's come from Sirona especially, and they've got a plan, really, I spoke to our pharmacist here, and he said if it's a discharge and it's going to be an ongoing medication, or it's a plan from Sirona, he's quite happy for it to go straight on repeat. You know, they'll keep us updated. So it is all about trying to make life easier for the patient. And if it's something like, I don't know, an Epimax, it's not going to hurt if it goes straight on repeat. It's only a moisturising cream. So, you know, like I said, it does make it a bit easier. And I think it makes the PMR, the patient's records, look a bit, it's easier to order their repeats and know what's going on if it's just a little bit of housekeeping done now and again. So, a repeat prescription. I don't know about patients in your area, but ours always seem to assume that if it's a repeat, it just means the doctor or the computer automatically issues it every week or every month. It doesn't. It just means they don't have to see a GP. Should be for long-term and chronic conditions, and like I said, they don't need to see the doctor. And also, there can be several issues made without a review, or batches can be issued as well. Be a fun drive home. Right, what can go wrong? If you think of anything in the chat box that's not on here, you know, if you think of anything, put it in the chat box, because, you know, we all probably see mostly the same thing, but there's always something else that goes wrong. Patients not ordering, you know, the pharmacy should give them their copy of their prescription, which would make it a lot easier for us. We get those handwritten ones still, and things are scrawled on there. You can't work out what they want, what's stopped. So I do ask patients if they can to go and get that up-to-date slip from the pharmacy so they know what they're ordering. I do a lot of this, I don't know about you, but it does help the patient and the pharmacies and the surgeries a lot. If patients' medication are all synchronised, so if I'm ordering somebody's prescription and I can see there's 56 of one, 28 of another, 84 of something else, I try and bring them all into one, like 2 months supply. Ring the patient then and try and do a one-off prescription. It can be difficult, but get them to get their medication all in order so they can just do it once. It just cuts our load down, and their trips to the pharmacy. Lots of patients are having problems with the apps at the moment. Patient access, I think, have been down for a couple of weeks. And again, patients seem to be having problems with how they order. The practice manager here has just had a group of patients in, teaching them how to use the NHS app and trying to get patients on that, and then they can teach other patients how to use it. So hopefully now more people will use the NHS app and we'll hopefully have less problems. And also take care when patients are asking for something that's not on their records. You know, who usually deals with your requests for patients will ring or they'll send in a slip and it's not on there? Is that the technician who deals with it, or is it the pharmacist who deals with it? Yeah, we still get a lot of paper requests from pharmacies and patients. No, we don't take them over the phone either. It doesn't help. People still try, even though we got a message on there saying we do not take requests. I mean, we do in certain circumstances, don't get me wrong. If we've got housebound patients and they're 97 and there's just, I don't know what it's like in your area, but none of the pharmacies here answer their phone. So that everybody phones us and gets quite irate when we say, well, sorry, we're not allowed to take them over the phone. So it is a bit of an issue. And we do it, like I said, for the older patients. I don't even do urgent requests over the phone because there shouldn't be urgent requests unless it's a palliative care patient. So I always say to them, you won't get it any quicker if I do it over the phone because there's still X amount of people in front of you. So try not to, because I find if you do that, patients will know then. Phone on a Friday afternoon and they'll have to deal with it. So yeah, I try not to take anything over the phone, like I said, unless the patient is older, or we've got a couple of patients, you know, who've got dyslexia and can't read or write and really struggle with it. So we will do that for those patients as well. Oh, you don't have the red line. Oh, heaven. We got about to have a fifth one through.
Well, we don't yet because we're kind of relatively new. Well, it's a year old, and it's 2 surgeries. We're at Lawrence Western, which is where I used to work for Pioneer until a few weeks ago. Well, I've been been doing both, but it's only their phone lines in. So because we're doing Shirehampton and the 3 Pioneer sites, they haven't worked out how they can do the whole phone line at the moment because they do work differently.
Yeah, and most of them are queries, and most of them are for, like I said, palliative care patients. It's a lot of carers phone us, and that's fine. A lot of older patients phone us. But we do get an awful lot of people phoning saying, "Where's my prescription?"
Yeah.
I can't get home to them. But it is impossible some days. You just can't answer all the phone calls. But there you are. If I didn't have the phone, I'd be bored. If I didn't have the patients on the phone, what would you do? You need those challenging patients to make your day. Right, common errors. Obviously, especially if they come from a discharge, you get wrong drug, wrong strength, incorrect or missing doses, short-term drugs, repeated long-term. Yeah, we get a lot of those. Items added by unqualified staff, items that should have only been acute put on repeat, and same drug repeated twice. Now today I had a request from a pharmacy to change a patient to weekly scripts because they were on a Dorset box. And I noticed since, 2016, the patient's been taking 40 milligrams of omeprazole and 15 milligrams of lansoprazole, and nobody's noticed. Not even the pharmacy requested both of them today. So that's an issue. You don't need both of those on there. So this is the problem sometimes when an error's happened, and let's say it's a massive error, one like that will go unnoticed for years. They trialled the lansoprazole in 2016, and they should have come off the omeprazole, but since then they've just been ordering both all the time. So today now I'm probably going to get a phone call from the patient. I'm going to write rant because I've stopped it. So yeah, watch that same drug repeated twice. It can easily happen.
We had the one exact same yesterday, actually.
Yeah, and you just look at it and you just think, no, that can't be. No, not all this time. But it does. So do you all work through your SOPs? Have you got policies? Have you got things in place that you know what you should be doing and where to go and what to do if it does go wrong? If you've got, it is hard with SOPs because you can become a little bit too SOP, but I think you do need them just to have a look back sometimes and see what you should be doing. And like I said, if you're ever unsure, if you've got a technician or a pharmacist there you go to people. We're quite lucky in this PCN. We've got a lot of pharmacists. So I think we've got about 8 now altogether. So it's about 2 a practice. Some people are part-time, but it's very rare we're without a pharmacist. There's always somebody to go to. So, I think we've got 67,000 patients. So it's always, we always need that backup, and it's just knowing who to go to and when. And it just means things will get solved quicker if you know where you're going with them. Right, so I know most people now have their nominated pharmacies, but do any of you use the EPS4 or the any pharmacy? So you can actually change it, so you can sort of bypass the nomination and change it to any pharmacy. So that's quite handy if the patient's on holiday, travelling, you know, work-wise. As long as it's in England. I don't think people outside England realise you're the only ones with electronic prescribing. Nobody else does it. So there's no good if they say, I'm going to Scotland, it's not going to work. So care homes as well. At the weekend, most of the pharmacies who supply the care homes will probably be closed. So they might have to go to one of the late night pharmacies. So if you can, you know, just try and get the doctors to understand if it's a care home at the weekend, just to send it EPS4. Stock issues. Yeah, we've all had the stock issues, the ADHD medication, your HRT medication. Again, if you send it EPS4, it means the patient can either use their NHS number or wait for you to text them the code and they can take the code in, but their NHS number will work just as well. And they can take that in then and the prescription can be downloaded. And it's much easier like that for the patients, especially like I said at the moment with the ADHD medication. You know, one of our practices student health, and they're all moving home now. They're coming to the end of their exams and they're moving home. So I'm tending to send a lot of theirs EPS4 now. So if they go back, Liverpool, Warrington, or wherever they're from, they'll still be able to get their prescription. So when you issue a prescription and you want it to go EPS4, you just go change all and then pick EPS, any pharmacy. And then, like I said, that will just sit on the spine until the patient walks into a pharmacy and gives them their NHS number, and then that pharmacy can download it for them. Right, roles, how it should work. Patient should request the prescription or the pharmacy. I know around England at the moment there's quite a few pilot projects going on where some places are actually taking the ordering off the pharmacies and saying it should only be the patient that orders. You know, we all got stories. I had one the other day, pharmacy ordered and said, I know the patient's had it last week, but he's going away. And I thought, that's a bit odd. So I phoned the patient up and I said, oh, are you going away? Can you just give us the dates? We'll make sure you've got enough medication. This pharmacy has requested for you. And he said, well, when I'm not going away, I've just moved pharmacies. So I emailed the pharmacy back and said, has there been some confusion? You've ordered for this patient, he's not going away and he's actually moved to another pharmacy. I didn't get a reply. So I'm not quite sure what happened there. So obviously we do try and encourage the patient to cut out the middleman and order it straightly with us, and then they know the prescription request has gone in. So then processing will be prescribing clerks or receptionists. Have you all got dedicated prescribing clerks, or are you doing dual roles? Because that gets quite hard when you're doing reception tasks and prescriptions, doesn't it? It is quite. Yeah, I think most places now have dedicated clerks, which it does make it easier. And the good thing about that is you can follow on your queries from the day before and the tasks that the GP sends you back. Yeah, if you're doing 2 roles, it's really difficult to juggle all of that then, isn't it? And I said, if you're swapping in and out, you miss the tasks, especially if they're urgent tasks. And obviously then, once you've sent the request, it's up to the pharmacist or the doctor or the nurse to sign it. We have, again, we're lucky, we've got a lot of independent prescribers, nurses and pharmacists who jump in and do most of the signing. And I do think in a few years, GPs won't get involved in signing repeat prescriptions. I hope not. I think they should move away from it. And then the more pharmacists and nurses we've got signing, the more appointments the GPs can have. So again, the simpler we make the process, that encourages the independent prescribers to be more confident in jumping in and signing them all. And that again sort of frees up that time for the GP. So every little step we make easier, it's hard to see, but it will free up time for the GP. And like you say, then the prescriptions get sent via EPS and should land at the pharmacy. Does anybody print prescriptions now? No, we don't. No, people do ask sometimes, and we just say no. We can't print. I've not set up the hub to print, so we haven't got a printer to print them anyway. So it's just much easier to send them electronically. Right, does anybody want a break, or do you want to just keep going through the afternoon? Or do you want time to go make a cup of tea or coffee? I really don't mind. Okay, should we just grab 10 minutes then, go make yourself a cuppa, listen to the rain, and I'll see you back. What time will we now? So see you back here about 5 to? Right, is everyone back? Oh, got to select that. Right, benefits of a good system. If you have a good system in place and everybody follows it, it'll improve care for patients. You will pick up more of those mistakes that happen. So that minimises risks to patients, risks of errors, also reduces medication waste, especially if you can synchronise everybody's medication and stop that sort of like 4 or 5 times a month ordering. And also just improves your time and your efficiency, and people got a lot more time to do other things if they're not trying to clear up their patient records all the time. Polyrun system, it is frustrating. And as Judith knows, at the moment, our area is having a massive problem with ERDs, which is causing so much anger with our patients and frustration for me and everybody else. So yeah, if we can get that sorted, I'll be a happy bunny. And you waste practice time and patients' time. You know, most people are working, they're all running about, they got kids, they don't want to spend 3 days chasing their prescription that they can't see on their app, and they realise there's actually an ERD sat there. And polyrun system is just a waste of NHS medication. And some of it is simple things that clerks might not know. Like we've got quite a lot of assisted living houses around here. So if they drop a medication, obviously it's assisted living, they can't pick it up and use it again. So through the month, they might lose 3 or 4 different tablets. The old manager used to know, just tag that onto the end of the monthly requests. So if they have 28, they've dropped 2, they need 30. We've got a new manager. She just sent a list through. She wants 1 tablet for this patient, 2 tablets for this patient. And I went, no, I'm not issuing a prescription for 1 tablet. They can wait until the end of the month. I don't think people understand just how much it costs to produce 1 prescription with 1 tablet on it. So it's knowing that and just explaining to the manager of these care homes, no, that's just not how we work. You always get your month for the next cycle before your other month is finished. So you can always take a couple out of there, then as soon as they come, you will have that extra medication in that delivery. I won't do an extra prescription for 1 or 2 tablets. And like I said, if things go wrong, it does cause mistakes and it causes a lot of complaints. Right, and waste is one of our biggest problems. This slide is a few years old now. It's probably cost more than that. Now prices have gone up. How old is Zoton? Right, can anybody guess? This was 1 patient. This was a patient who died, and this was what was brought from the house. Now I can count 1, 2, 3, 4, 5, 6, 7, 8. I can see 8 boxes of Crestor 40 milligrams there straight away. So and most of this is unopened. So how much do you think that cost? And like I said, this was probably about 5 years old, this slide, so prices are a bit out by now. Oh, care homes should definitely not have waste. Care homes should be well on top of their stuff without wastage. Right, I will tap it in here because it's quite surprising how much it is. That, like I said, about 5 years ago, was £4.5 grand worth. And I worked for the Health Board in Wales for 5 years before I came here, and we did a big project on waste, and I was in Barry, and we were asking people to bring their waste, and in the end we were saying, right, take it to your pharmacies. In the end, the pharmacies complained to us because they had so much waste brought back, which I can understand. And this is where your systems have got to be good. And you will upset patients along the way when you say your request is too early. But they just have to, you just have to explain to them, you had 2 months 5 weeks ago. You can't have another 2 months now, because this is what happens. And people, they don't like to think that they don't know what they're doing. But if they don't know what they're taking it for, they'll stop taking it. So I did speak to one prescription clerk at one session, and she said, especially for their older patients and their patients on a lot of meds, they've started to put on there what they're for. Well, brilliant idea. Because if you don't know, why would you take them? And this is where meds reviews come in. You know, I had a gentleman phone me up the other day, and he said, I need to order my prescriptions, but to be honest with you, I don't know what half of it's for. So I said, right, okay, I'll book you on an appointment with one of our pharmacists. They will go through everything with you and explain what it's all for. And that's what the review is there for as well. It's to help the patient understand what it's for, why they need to take it, and for the patient to also explain to them, well, maybe actually this will I get a side effect from. Well, we can change that, we can do things about that. But unless you speak to them, you'll never know. And I don't know how you manage it, but when I was in community pharmacy, and I noticed a lot here, we'll have a lot of patients with the same name. And when I was in Cardiff working for the community pharmacy, we had a dad and a son, and the son was in his 50s, dad was probably in his 70s. They were both diabetic, they both had the same name. At the time I was doing dosage boxes, and my boss said to me, look, we've got a problem with these two. Can you just pop round the house and see what's going on? Something's going wrong with their meds, it's all over the place. So they were a lovely family, so I went round, and he said, oh yeah, I'm having a bit of problems coming in. And he literally pulled the settee away, and there was just bags and bags of meds. And he said, the problem is, we've both got the same name and we don't know what they're for because we're both diabetic. So we had to label it Junior, even though he was in his 50s. And then the dad, and then him Junior, because they just, I just took away bags and bags of it, sorted out all the stuff that was in date, relabeled it all and just took it back round. And they probably didn't order for about 6 months because they're just not taking anything, which is dangerous. They were both diabetics. They needed to take their meds. So anytime you see people just struggling when they're ordering their medication, and you just think, well, they only ordered this last week, why are they ordering it again? Just phone them up and just ask them, you know, are they coping? Do they know what they're taking their medication for? Is there anything you can do? And most of the time, they're just grateful that somebody's noticed something's not right and phoned them up. You know, not asking 100 questions, just saying, is there anything we can do to help? So, yeah, I think this is one of our biggest problems. And hopefully having a good system in place will stop that. And I noticed when we started the hub and we started rejecting people's medication, they were so angry at us. Who are you to do that? What gives you the right? But somebody has to maintain this system. Somebody has to have some control over it. So this is one of the biggest problems. We haven't got many, but if there's no directions on something, I will always put a note to the doctor and say, we need directions on this, or otherwise the patient doesn't know what they're doing and they can just keep ordering because we don't know what they're doing. So if you can make sure that there is proper directions on things. Obviously, you're not going to get it on warfarin or insulin. I've done it with insulin, though. I phone patients up and check what they're taking, because doctors do get confused with how many packs are in an insulin box. So it's usually 5 cartridges or 5 pens. And in Cardiff, we had a big problem where they thought they were ordering 5, and on the system we use over there, which is Vision, you were ordering 5 boxes. So my biggest question was, well, where are all these extra boxes going? Look on eBay, everybody was selling their Lantus for £25 a box. Yeah. And the Americans will buy it because it's cheaper. So I kept reporting it to eBay, saying, well, this is prescription only, this is prescription only. So then we started doing this big project of phoning up patients saying, well, actually, what dose are you taking? And most of them only needed 1 box for a week, for a month. And they were getting 5 boxes a month. I've actually got, if anybody wants it, I've actually got a sort of a sheet that tells you how much the patient is taking, if their dose is this, how many boxes they need a month. And it breaks it all down to exactly how many they need. And, you know, if you can see a patient's having 5 boxes and hasn't ordered them since last August, well, I would phone the patient then and say, look, can you just give me an idea what your dose is? I'll look at the sheet and go, right, you only need 2 boxes, and I'll change it to 2 boxes. Because there is, at the moment, we've got an insulin shortage with 1 make already. So sending out 5 boxes because the doctors think they mean 5 pens, not 5 boxes of pens, it's just, you know, it's just going to cause more problems with the shortages at the moment. So it is worth it. Definitely, if you see somebody not ordering insulin for 6 months because they've got all those boxes, just ring them and ask them, and then you can work out from the sheet exactly how many they need to be given a month. They don't want it in their fridge either. You know, there's not much room in your fridges without 5 boxes of insulin. And you know what it's like, the pharmacies will just keep ordering it every month. And then the patient just ends up with boxes and boxes of it stuck in the fridge. Yeah, like I said, align all your medication to 28 or 56. Do many of you give much more than 2 months supply? We do have a few on 84 days, but not many. Most of them are 2 months. So I just try and go with what's the most. So they got 10 items, they got 6 on 2 months and 4 on 1. They'll all go on 2 months just to make it easier. Yeah, contraceptive pills are different. They can have 6 months of those. HRT, we tend to give out 3. Yeah, travelling's a bit of a bone of contention at the moment. How much do all your practices give for travelling? We've got a maximum of 3 months. After that, they need to think about where they're travelling and how long they're going to be out the country for. I did have a diabetic patient, type 1, yesterday, who was going to America for 4 months. So yes, in certain cases, yeah, we gave her 4 months because American insulin, she might not get the same over there. So yeah, there is always that odd case, and you do go above and beyond, and that she was one of them. Yeah, 3 months is usually the thing. But around here, we've got a lot of people who spend 6 months in France, 6 months here. But really, if they're spending 6 months in France, they should be getting their medication in France. And again, I don't think it's quite as easy to do it on EMIS as it is on Vision, or I think there's another one, Microsoft. But don't put OP if you can help it, because they're all different. Some are 30, some are 28, some packs are 56. So you don't really, you know, OP doesn't really help. It's better to put 28 days or 56. And like I said, always check that what the doctor's written. If it's 2 a day, is 56, you know, tablets for a month's supply. Make sure they add up. Because again, patients just get so irate if one of them doesn't equal the right amount. So all those quantities, again, will help your system flow better, just makes it easier to order, less chance of errors. Yeah, synchronization. Do a lot of you sync meds? Or do you, yeah. I tend to, I don't know what you do, but I tend to take all the creams off and put them on variable repeat. So the only things on repeat is their tablets and things like that you can definitely synchronize. And then when it comes to it, I'll try and get it so that everything can be ordered at the same time. And you do get some patients who don't want it. I had one lady who said she pays for a prescription, so she just picks the medication she needs at that time because she's not entitled to free prescriptions. But she was on thyroxine and she was entitled to free prescriptions. And I've been paying for years and nobody had noticed. The pharmacy had not even told her, even though she was going to the pharmacy every month and paying for a prescription. They never once said to her, "You're on thyroxine, you shouldn't be paying for this." So even if you're just synchronizing people's medication, you pick up other errors there while you're looking at it, thinking, "Oh, wait there." So again, try and make sure everything is for 1 or 2 months supply. And especially if the patient's on 4 or more items and you can see him ordering every week, different items. I've got a spreadsheet if any of you want it, that's got 28, 56 and 84 days on it. So you just fill in the quantity the patient's got and it will just automatically generate what you need to do a one-off prescription. So much quicker. So the patient just counts all their medication. You look at it, all right, 56 days. So if you say he's got 26 or 12 astatin, it will just generate, oh, you need another 30 for 2 months supply, and it'll just give you all the quantities straight off. So if you want it, just email me after. I'll put let me just put my email address in here now before I forget. Just send me an email and I'll just send you a copy of the synchronization sheet. Like I said, it's just so much easier. So yeah, I probably do a couple a day now, and it's one time that you make the pharmacist happy, your patient's happy, and the GP happy. It's the one time everybody's got a smile on their face. Right, having a look at this now. This is, say, a patient's PMR in your surgery. Is there anything on there? This should be a 2-month supply. Well, I'd go 2 months, but is there anything on there you would change? I mean, you can tap it in the chat or you can turn your mics on and, you know. What about the Avamis, Libby? What would you say is wrong with it?
The one OP.
Yeah, and
I'm just daily, like.
yeah, it's directions as well are wrong. It should be 2 sprays and then reduce when the symptoms have got better. So yeah, the OP's wrong and the directions are wrong. That should go down to 1 spray when things have stabilised. Yeah, we wouldn't give 5 hydroxychloroquine. We never say it.
We normally just issue. We normally just issue 1 every 3 months.
Yes, yeah, that's all we do is just 1. I think, to be honest, there's not many. Most people now are either taking tablets or they seem to have come off that since COVID. Lots of people miss their every month and have just seemed to have dropped off and don't seem to do it much now. Anything else on there that anybody would change?
The eye drops.
I'll give you a clue. What size does lamtanopros eye drops come in?
Like 10 mil.
Now they're a 2.5 ml bottle, so that's 4 bottles altogether. Really, for 2 months, they would only need 5 mils. Yeah, all this old Latin stuff really needs to go, because the new check-in systems especially don't recognise them. So I'm trying to change them. Plus amoxicillin, it's on a repeat prescription list. It shouldn't be, not at that dose anyway. So that should definitely go. And also Losec and omeprazole, it's the same thing. Obviously the omeprazole is going to be the cheaper one. And the simvastatin, yeah, that one at night. And I've spoken to a couple of pharmacies around here. The new systems are not even recognising the one. So it's got to be typed as it would be seen in EMIS. So yeah, we've got to get away from the Latin TDS and things like that now. So if you see it, or you see 1 or 2, just try and type it as one, you know, type it properly as it comes up on EMIS, because it's more work for the pharmacies otherwise, and it's more waiting for the patient. And yeah, again, if you can make it simpler and just make it easier for everyone, it's just so much better. Right, things that can be prescribed. It's not just medication, is it? We have lots of different forms, and sometimes, you know, the difference in dosages when you've got an LA or an ordinary tablet is different. If you want patients who want to go to liquids, that doesn't switch easily either. Obviously, we do a lot of pessaries with the HRT. And then you've got all the other appliances. You've got your stoma appliances, your hosiery, catheters, all these specialised things. But again, with all of these, there can be errors. I've done a lot of work with the stoma nurses in Southmead and in Cardiff. And we were doing a review on patient, and the patient had been given Fortisip, but they were a stoma patient and they'd been given Fortisip fibre, which is the worst thing you can do to a stoma patient. So you might think, oh, it's only a drink, but it's always worth double checking, because it can still go wrong. Stoma appliances, again, people swap a lot. There's a lot of reviews going around, a lot being done at the moment by the stoma team out of Southmead. So just because your stoma patients had the same bag for the last 15 years, they might start to change, because they're out there doing the reviews. So, you know, as much as you can, always double check, because the last thing you want is your patients running out of their stoma supplies or their catheters. Lymphedema gammas, I don't see so many now. I don't know if there's, it's more coming out of the specialist clinics now, but I don't see many prescriptions for lymphedema gammas over here. Right, so obviously people don't always have to go to their doctors to get medication. You can go on the internet and buy stuff. You know, you still got to be careful where you're buying them from. You can go to private pharmacies online and have a consultation with a pharmacist and get medication prescribed. Community pharmacy can sell stuff, and also they've got the new services now up and running. And supermarkets and convenience stores. So there's a lot for the patient to take in from all of these places they can get the medication from. But I would say to them, I'd try and avoid the internet, because I'm not going to get much information about where it's come from or anything. Now, here's our Latin we're trying to get rid of. So the patient doesn't need to know what it means. The pharmacy does when it's on there. But again, if it's the dispenser in the pharmacy who's changing it because their system can't pull it down, or it won't, the new systems print exactly what it sees. So if it's got one Nocte on there, that's what it'll print. So if that dispenser doesn't know what that means, and the patient doesn't know what it means, it's just might as well not have any directions on it at all. So yeah, if you see it, just try and change it, because like I said, the new systems don't understand it. And the pharmacists I've spoken to coming out of university now, they're not even being taught it, so they don't know what it is. So it is going to cause a lot of problems now with this new system if we don't change it. So I think it's in the back of the BNF, this, but if anybody again wants a copy of it, it'll be on the slides, and the slides will go round anyway, so you should be able to just print that page. But the idea of this, the Latin, was that back in the day when I started, patients weren't supposed to know what they were taking. If a patient came into the pharmacy and said, look, I've been given this medication, what's it for? Your first thing would be, well, what did you go to the doctors for? Because patients were never supposed to know. The label would say their medicine, their tablet, their cream. It didn't change for a long time. I think when computers came in and you didn't have to handwrite a label, then we started putting the name of the medication on it. Until then, there was none. And the idea of putting that on there was only the doctor and the pharmacist should know. It was meant for the learned people, not for the general public to know what they were doing. So the law didn't change until 1972, when they said then you've got to start phasing out the old system and start bringing in the new, when you put the name of the medication on it and you put the right directions on it. So yeah, I think eventually this will all go. So like I said, if you've got any old labels or any old sort of instructions on your system with any of these on there, just take them off and just type them the normal way as it is now. Right, I don't know if you all know that there's different classes of medication. So there's your general sales medication, which you can just go into any shop and buy paracetamol or a cream. And then there's what we call a P medication, which is pharmacy only. So that'll be your more like, you know, cocodamals with codeine in, Migraleave, you know, certain medications that you could only buy if a pharmacist is on the premises. And years ago, we used to have to ring a bell to say and shout, selling Solpadeine, just so the pharmacist could stick his head out and see who we were selling it to. It's more open now, we've got more open dispensaries, but years ago they were all closed. So if you sold anything that was a P, what we class as a P medication, you had to let the pharmacist know you were doing it, because it's only, if the pharmacist went to lunch, you would not be allowed to sell it, and you still can't. If a pharmacist is not on the premises, you cannot sell a Migraleave, cocodamol, lots of things really. So yeah, if you ever go into a pharmacy and ask for something, they go, we can't, we've got a pharmacist, that's why. And then you've also got prescription only medication, which is what we tend to deal with every day. And they either have to have an NHS prescription or a private prescription. Ooh, my favourites, generics. Like I said, we're used to them now. We've worked with generics for a long time, but when I first started, there were no generics. Everything was branded. Furosemide, everything. So patients are still trying to get used to generics, I think. And then we've got branded generics, which makes it even more confusing. So generics are usually the cheaper name. They often have very long names like Pidgegel, whereas the branded name is a short, sharp, quick Plavix. It's a scientific, it's just the name of the drug. So Nurofen came out first, now the cheap one is ibuprofen. And I don't think now that the license and the patent lasts as long as it used to on them. So generics come out, new drugs come out, and the generic seems to come out a year later, whereas before it was like 10 years. but they are the cheapest way to prescribe, and whether the patients prefer it or not, it's going that it's going to be generics and that's it. Like I said, the branded medication tends to be that short, sharp name, but it's not recognised worldwide with the generic name, so with the branded name. So I didn't know this. Tylenol is Panadol in America. I thought Tylenol was sort of like Cocodamol, but it's not. It's just paracetamol. So that's, I think, why branded names are going. It'll become all generic just so it's worldwide rather than just in certain countries, certain brands. Explain it to patients. I think it's okay when you switch into a generic, but are you all doing the switch now to the HRT progesterone? Yeah. It's not going well, is it? That's a branded generic, because Gepratix is not a generic and it's not a brand. It's a branded generic. And I was trying to explain this to a patient, and she just went, "You're having a laugh." I was going, "No, I'm not, honestly." I said, because she said, "Is it a generic or is it a brand?" I said, "It's a branded generic." And it is what it is. It shouldn't make any difference. It should be the same. They shouldn't have any side effects from it. And they could look different, but the generic name should always be the same. It's progesterone, whether it's Utigestion or whether it's Gepratix. The only time the patient will have a problem with it is that the drug name is exactly the same. It's the excipients that it's mixed with which are different. So they all use different gelatin, they all use different powders to mix that all in. So patients will phone up and say, "Well, I didn't get on with it, it made me feel really sick." And they could be right, because what they mix it with will be different. But I am asking patients now, we've switched to, especially the HRT, just to give it a try for a month before they give up on it, you know, and want to go straight back. And they'll say, "But my consultant gave this to me." But yeah, that's just because it's the only name they know. They don't really understand it. So unfortunately, at the moment, we are very cost driven. And it is, I don't lie to patients. I do say, sorry, it's cost driven. We do need to save money. Just give it a try and just see. And to be fair, touch wood, the ones I've asked, nobody's come back and switched back to the Utigestion yet. They've given it a go and they've found it's no different and they've stuck with it. So do try and persuade them just to give it a try for a month before they sort of just think no. I don't know, do any of you use the BNF much? Do you use the electronic one? Because that's quite good, because it will tell you what's a brand, what's a generic. Because there's so many brands out there now that it's really hard to track them. I know on EMIS you can have a look on drug history and it does, drug information, it does tell you all the different brands, but you can get it up online with the BNF, and it will give you a list of all the different brands that are, because some hospitals, especially renal wards, will always prescribe by brand. And sometimes you just have to stick to that brand, and it's just nice to know which ones are which. And again, all this switching sometimes will cause problems with patients' compliance, because one minute they've got one thing, next month they've got something different. It's changed colour, it's changed boxes, it's changed names. And especially for older patients, it can get really confusing. I did Dosset boxes for 8 years and I had my own stock, and all my patients had the same colours every month, because I got to understand that's how they look at their box. It's by colours. And all of a sudden, these older patients now, they've gone from a simple name like Plavix in a blue box to a red box with white writing that says Clopidogrel. How do they know it's the same? They don't, do they? And this is where the compliance problem starts. They're not taking it because they don't know if they've got the right stuff. But they can't get through to the pharmacies because they don't answer. They've got nobody to ask. So straight away it's, oh, I just won't take it. It's just easier not to take it. And that comes under unsure what they're prescribed for, unable to open or administer eye drops. We have loads of problems with older patients with arthritis who can't use their eye drops. You can prescribe dropper aids. So if you see patients having like 6 bottles of eye drops a month, I do try and ring them and say, you know, are you having problems with your eye drops? Do you need a dropper aid to help you? Because they just fit in, the bottle just fits into there, and it's a hard plastic device that then just cups over the eye so that it's stable, it doesn't move. So then their drops go in straight away. They're not there trying to get them in. And some of the cheaper brands are just impossible. They just run down the side of your face. So yeah, again, you know, if you see a patient and you see them asking every month for more and more eye drops, just give them a ring and say, look, you're struggling with them. Because, you know, eye drop bottles are like that big. When you've got arthritis, it's impossible. So they could have confusion or memory problems. That's a bit difficult to sort out because even a Dosset box is not going to sort that problem out. You know, there are Dosset boxes out there that alarm. If a patient's forgotten what that alarm's for, it doesn't mean anything anyway. So, you know, when your patient is not compliant and you can see things are going wrong, you do need to speak to them and try and find out, have they got help? Have they got a neighbour or a relative that can come in and help them? Because, like I said, most of our pharmacies now, they're struggling with their Dosset boxes. They've reached capacity. And like I said, if they're a patient with confusion or memory problem, it's not really going to help. Non-compliance, again, it causes medicines waste because, like I said, it just gets left on the side. They end up in hospital. Worst case scenario, they can end up dead because they're just not taking their diabetes medication because they didn't realise that's what it was for. And again, this is what the medication reviews are about. It seems obvious to us, but to a 93-year-old patient, it's not obvious. So just a little chat, just to say, you know, what can we do? Is there anything we can do to help? I'm not going to play the video, but this is all about dementia. And there is, do any of you belong to the Dementia Friends? There's a website called Dementia Friends. It's really good. It's really useful. It'll tell you all the up and coming things that are going on, the nearest groups to you in your area. And if you can get on there, it doesn't cost anything. This is a really good video. And it just explains what this lady Barbara is basically an ex-school teacher, headmistress, and now she's got dementia. And it just explains it from her perspective, what it's like to go into one of these big new all singing all dancing Southmead hospital types, where you're used to just going to your local doctor, who years ago used to be the front room with the house at the end of the street. And it's really, really good to watch because, you know, as we get older, I know my short memory's going, hence I've got to write everything down. So if you think of your brain as a bookcase, when you know, in your childhood, teenage years, everything's lovely, everything's stacked nice and straight and in perfect order, including your feelings, emotions, memories, everything. But as you get older, the logic and the fact and the reason go, and it just all falls apart. So you remember your childhood and your teenage years, but you've got gaps everywhere else as well in your memories. So it's quite difficult for them to remember what they're taking their medication for, to even remember what that bag sat in the corner is. You know, I was doing stoma clinics one day and we had a stoma patient who was a dementia patient, and we reminded her about this review. I went downstairs, there was no sign of her, and I said to the receptionist, oh, has she been in? oh yeah, she came to collect a prescription. We thought she'd remember. No, we should have nabbed her there and then, but she'd forgotten. She actually came into the surgery and just thought prescription. I just totally forgot about her appointment. So, and this is what I said about dosset boxes. They don't work for those patients. They're never going to work for those patients. So we've just got to try and think of another way or another way of supporting them. Now, last bit, girls, not long to go. Confidentiality. Which gets sort of more difficult now with the more people working in the practices, the more screens you've got going, and how easy it is for patients coming into a practice and see what's going on. We're downstairs and we've got a big, massive sign with no entry on it. The amount of people that open that door. And there's screens all over the place because there's like 6 of us in a small room. So we've taken to locking it now because I can't have people walking in there and seeing patients' PMRs in front of them. So even making a phone call on the front desk is, you know, difficult. Like I said, computer screens, paperwork left on tops. Well, even, I don't know how you manage it in your practices, but even at the reception desks, you know, with patients queue really close together, you know, there's people in front of them. And making sure that all your paperwork with your patient details is on, even if it's just notes from the day before, lock them away. Don't leave them out overnight because really nobody should see them. So we all know now about all the GDPR, access to health records. Are many of you getting any requests for access to health records now, or are people just happy to see what they got on their app? I mean, we don't very rarely, because I think everything's on the app now, so people can usually see it. But again, even when if we do get patients asking for it, I just send them to the practice manager because it's, you know, it's not up to me to share all that data. You can't disclose patients' information. Obviously, there are times when you can, if district nurses, hospital services, or any other healthcare department needs it. I had one surgery in Cardiff refusing to send prescriptions to a dispensing appliance company because they said that broke GDPR. I said, well, why you send a prescription to the pharmacy? It's the pharmacy. So interpreting the rules as well can be a little bit foggy. And like I said, we can share information when it's child protection cases, or for any other planned services for that patient. And again, when the patient agrees. Again, that can be a bit difficult over the phone when you've got a neighbour who's just popped in to see their elderly neighbour who now needs to speak to us. And, you know, I always say to them, look, can I just have a quick chat just to see if this is okay? So always make sure that you get that. Yes, I can speak for this patient, even if it's verbal. If it's over the phone, all our phone calls are recorded now. Everybody should be on the cloud now, shouldn't they? All your phone calls should be recorded. So that consent is fine. Right, pharmacy first. This is just a little bit we put on the end now because obviously there's this new pharmacy first service come out. I think in Wales we've been probably running with it for about 10 years now, and it works really well over there. I can go and get hay fever tablets and hay fever eye drops and nasal sprays every month now for the whole of the season. It's from my pharmacy. So the more you use it, the more the pharmacies will do, and the easier it is. I think for us in Wales it's different because we don't pay for our prescriptions. There's a lot of things we're not allowed to have on prescription, including hay fever stuff and paracetamol. We just go to the pharmacy and get it on this pharmacy first system. It's great if you're working. It hasn't got to come through the surgery. The patient can go in themselves and just say, I need something for my hay fever. Can I have an appointment with the pharmacist? Eventually they'll be doing contraception, and that will be initial and further supplies. So that will be really good. Good for the pharmacies team. They get more work to do. They get different work to do. And the GP practices, they're not blocked up with people just coming in for hay fever tablets and eye drops. And even in Wales, if you've got an eye infection, I could never call my doctor for an eye infection. I just walk into the nearest pharmacy. There's no appointment needed. You just walk straight in. So, you know, if a patient phones up and says, look, I can't get an appointment and I think I might have a UTI or I've got an eye infection, I need hay fever things, send them to the pharmacy. I think you can do referrals as well. I think the pharmacies prefer referrals here. But if you look at the actual DES for pharmacy first, they don't need a referral. You can just walk in. And they can do UTI, sore throat, impetigo, otis media, shingles, sinusitis, and infected insect bites. That's the new ones at the moment. I think that will, the more people that sign up for it, the more things that will go on. I mean, in Wales as well, we do test and treat. So if you've got a sore throat, they'll swab it. If you need antibiotics, you get antibiotics there and then, without going to the doctors. So I think it is more about freeing up the doctors to see more urgent cases. And most of like the hay fever things, especially, you can buy over the counter. Scabies, you can buy scabies treatment over the counter. So all of that stuff really should be going to the pharmacy. Right, girls, thank you very much. Feedback forms. So if you could do the feedback, that would be great. If you're having trouble scanning this code, because to be honest with you, I'm not quite up on QR codes. They never seem to work for me. If it doesn't work, or if you haven't got a feedback form, just let me know and I'll get Millie to send one out so everybody can send it in, can send one in, and then you'll get your certificate of attendance. And like I said, if you need the med synchronisation sheet or anything like that, just give me a shout and I'll email it over. And then next week is going to be level 2, and we'll be doing a lot about appliances and things then. And Judith ERDs. I think there's a bit in there about ERDs. I'm learning more and more though every day as well on them. We will get there. We will make it better. But thank you all for coming, and sorry I didn't turn up last week as I won very well last week, but thank you all for coming again this week, and we'll do level 2 next week, and yeah, go through any appliance problems you have and ERD problems. Judith, will you be here for the second one as well?
I will,
yeah.
I will. Mm-hmm.
But I'll probably speak to you before, so if not, I'll see you all next week, and thank you very much for coming.
See you later.
Okay,
Bye.
bye.
Bye-bye.
Bye-bye.
Bye, thank you.